Good morning. I'm trying to answer this tough question today. Should all pre-op bariatric patients stop smoking? I do not have any disclosure. So actually, I have one disclosure. I haven't smoked so far. So the answer ideally is yes. All pre-op bariatric patients should stop smoking. But in reality, I'm not sure. If we don't operate on patients who smoke, probably we're going to exclude too many patients who would benefit from the surgery. We know surgery can improve the obesity and can improve the comorbid conditions of obesity. Diabetes, hypertension, hyperlipidemia is associated with improved survival. So if we exclude those patients, then those patients wouldn't get benefit from the surgery. And in fact, in 2015, over 1 billion people, which was about 20% of world population, smoked tobacco. And so my question is, how common is the smoking among patients with severe obesity? So you see there is a positive correlation between the body mass index and the frequency of smoking. A patient with morbid obesity has a twofold increased risk of becoming a smoker. So the smoking is a problem in the societies, but even is more common in patients with severe obesity. So somebody may think that let's ask patients, let's educate patients, let's force patients to quit smoking before surgery. Do you think that would help? I'm going to show you some slide that shows that wouldn't help in many patients. That's data from the US veterans, which showed that all patients who did quit smoking within 6 months before surgery restarted smoking within 2 years following surgery. The most recent data on 78 patients who underwent bariatric surgery at 12 months post-surgery, only 5% didn't restart smoking. Or data at Cleveland Clinic on 35 patients who smoked within a year before sleeve gastrectomy. We followed them, and so we asked patients to stop smoking. We encourage them, we educate them, but only 70 of those 35%, 25 of them, which is 71% of the patients, restarted smoking after sleeve. The median time of quitting before surgery was 3 months, and the average time after sleeve to start smoking was 5 months, with a range of 2 to 12 months. This is another data from JAMA surgery. It shows frequency of cigarette smoking was pretty stable from baseline up to 2 years after bariatric surgery. Few more studies all showed that prevalence of smoking doesn't change from pre-op to post-op period. So if we educate patients, if we force patients to stop smoking, most likely the patient gonna start smoking again after surgery, so that's not gonna work. So, but what are the risks of surgery in patients who smoke? You know, bariatric surgery is very safe in current practice. If we want to study the effect of smoking on the complications of the bariatric surgery, we need a large sample size of patients because it's a very safe procedure. And in addition to that, the incidence of each individual complication is very low. So most studies use a composite outcome, which include 5, 10, 15 different individual outcomes put in together to study the effect of smoking on the overall outcomes. I'm going to show you some early and late post-op complications after the sleeve and bypass in patients who smoke separately. In 1958, the association between the smoking and peptic ulcer was established. Nicotine is a vasoconstrictor substance which causes gastric mucosal ischemia and predisposes to the ulcer. And you know the association between the smoking and marginal ulceration after gastric bypass is well established. There are several studies which have shown that 1 out of 3 patients with marginal ulcer is a smoker. And overall, smoking increased risk of marginal ulceration by 2.5-fold. And you know, marginal ulcer is not a good complication. Patient can bleed, and the ulcer can perforate. It can be life-threatening complication. So I think in patients who actively smoking gastric bypass wouldn't be a good choice because the risk of marginal ulceration and the complication associated with that. How about the immediate risk of the surgery in patients who smoke? The first study was published in 2006 by Livingstone based on the US veterans data in 12 centers, relatively old data, where smoking was independent risk factor of composite adverse event. And this study did show that extensive smoking history was associated with difficulty in weaning from ventilator. More recent study from the state of Michigan on 25,000 patients, again, did show that smoking was risk factor for 30-day serious morbidity. This data comes from American College of Surgeons database on 33,000 patients just after gastric bypass on the 30-day post-op outcome. Smoking was associated with higher risk of early post-op reoperation, pneumonia, sepsis, and shock. And this data again is from the American College of Surgeons, just on patients with low BMI, 1,300 patients with low BMI. So smoking was predictor of 30-day post-op composite morbidity. So all of these data showed that in gastric bypass patients, smoking increased risk of immediate post-op complication and can be associated with marginal ulcer in long term. How about the sleeve gastrectomy? So we studied the effect of smoking on sleeve patients on the US bariatric database. Data comes from the American College of Surgeons. So we included all sleeve patients between 2010 and 2014. 30,000 were non-smoker, 3,000 was a smoker, all the sleeve patients. And as you see here, the composite morbidity, early post-op composite morbidity, which includes 15 different variables, was 4.3% in smoker versus 3.7% in non-smoker. And the difference was significant, but you see the difference, the absolute difference was only 0.6%. Same thing with the serious morbidity. It was higher in a smoker compared to the non-smoker, but the difference was small. It was statistically significant, but I'm not sure if it was clinically important or not. And the mortality, see, 0.2% versus 0.1%, it was statistically very significant, but the absolute difference was minimal. So we concluded that the sleeve is very safe procedure in smokers and non-smokers, or we can say that the sleeve is a well-tolerated procedures in smokers and non-smokers. And we know that there is no long-term risk with the sleeve in smokers with the marginal ulceration because there is no anastomosis. So what would be the justification to do sleeve in smoker patients? Let me ask you in a different way. So what's the ultimate goal of bariatric surgery? Why do we do bariatric surgery? So the ultimate goal is to improve survival and quality of life of patients. And what would be the main reason for improved survival after bariatric surgery? So multiple studies have shown that the main reason for improved survival is reduction in cardiovascular mortality after these procedures. And who are at the greatest risk for the cardiovascular mortality? I think smokers who have metabolic disease, who have diabetes, hypertension, dyslipidemia, because these have synergistic effects on the cardiovascular disease and cardiovascular mortality. So who would benefit the most from bariatric surgery? Smokers who are at the highest risk for the cardiovascular mortality. So if we can decrease the burden of diabetes, hypertension, dyslipidemia, then those patients would benefit the most from these procedures. So we look at the cardiovascular benefit that the patient may gain in a very small sample size of a patient, 35 patients who smoked within 1 year of sleep at the Cleveland Clinic. We followed them for 4 years. BMI dropped by about 10 points. 86% had improvement in their diabetes, 60% had improvement in the hypertension, and we then calculated the Framingham risk score, which predict the 10-year risk of cardiovascular event, and the data did show that the sleeve patients who smoked at the time of the surgery, despite 71% of them restarted smoking after surgery, had 37% reduction in predicted risk of cardiovascular event in 10 years. So smokers would benefit the most from the surgery. At the same time, smokers have higher early post-op complications, so we need to assess the risk and benefit of sleep in the smokers. So the next question would be this: is smoking cessation associated with improved perioperative outcome? There is no literature on bariatric surgery, but the overall answer is yes. There are several studies, high-quality studies, systematic reviews, meta-analysis on different surgical disciplines, which have shown that if we stop smoking before surgery, the overall risk, the overall mortality risk of pulmonary complications, the risk of pneumonia, prolonged intubation, wound problems going to decrease. So it's well established. But the difficult question would be the optimal time. What would be the optimal time interval between the smoking cessation and bariatric surgery? This study was just published last month in surgical endoscopy based on the data from the state of Michigan in the United States. They included more than about almost 50,000 patients sleeve and bypass, and the primary endpoint was 30-day complication rate, overall complication rate, and serious morbidity. And they categorized patients to 3 groups: never smokers, former smokers who stopped smoking more than 12 months prior to the surgery, and recent smokers who smoked between 3 to 12 months before the surgery. So on the sleeve group, as you see here, there was no difference in any complication or serious morbidity among the 3 groups. That means if the patient stopped smoking 3 months before the sleeve, the risk of complication would be similar to patients who never smoked. The risk of early post-op complication would be similar to patients who never smoked. But in the bypass group, as you see here on the serious complication, if patients stop smoking between 3 to 12 months after before the surgery, the risk was still higher compared to patients who never smoked. So the authors concluded that short period of smoking cessation, which was between 3 to 12 months before the gastric bypass, would be insufficient to neutralize the negative effect of smoking on the early post-op complications after gastric bypass. So to summarize, smoking is a common problem, and it's even more common in bariatric surgical population in patients with severe obesity. If we encourage, if we educate the patient to stop smoking right before surgery, to get the surgery, the data is clear that there is high relapse rate after surgery, especially if the patient stops smoking within 6 months before surgery. We know that smoking increased risk of marginal ulcer after gastric bypass, and the ulcer can bleed, can perforate, can be life-threatening. And data shows that smoking increases early post-op complications after sleeve and after bypass. Patients should be encouraged to quit smoking before any type of surgery, including bariatric surgery. However, the optimal interval between quit and surgery is largely unknown. Maybe 6 to 12 months before bypass or 3 months before sleep should be enough. So the take-home message of this presentation: to decrease risk of complications, early post-op complication, and to decrease risk of relapse, which if occur can be associated with marginal ulceration, smoking should be stopped 6 to 12 months before gastric bypass. Sleeve gastrectomy is a well-tolerated procedure in non-smokers and smokers. Cardiovascular benefits of bariatric surgery, sleeve gastrectomy would be more pronounced in smokers. Sleeve gastrectomy would be considered in selected patients who cannot quit smoking before surgery. Thank you.